Hi guys, welcome back to the channel. Today we discuss the CLOVERS trials. This is a landmark trial, early restrictive or liberal fluid management for sepsis-induced hypotension. Kindly subscribe to my channel, Meditalk by Dr. Bhushan. You get a new trials and new PPTs there.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of some whatever. Under any circumstances, the author accept no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Clinical question for this trial. In a patient with a sepsis-induced hypotension, does restrictive fluid strategy with early vasopressor usage compared to the liberal fluid strategy result in lower mortality before discharge by day 19? Background for this trial: the 2021 Surviving Sepsis Guidelines recommended the use of large volume of fluid, 30 ml per kg, during the initial resuscitative phase of a septic shock. This, however, is based on the low quality evidence, with only weak low quality recommendation in the above guidelines. The practice varies widely, with Australian observation study showing the median of 4.2 liter of fluid given to septic patients within the first 24 hours. The recently published classic trial showed no difference in 90-day mortality when comparing the restrictive fluid strategy to standard care. However, randomization for this trial occurred in ICU after the initial fluid resuscitation. In earlier video with the classic trial, you can see the triangle. I will pin in the comment. Design for this study: this is a multi-center, randomized, unblinded, superior trial. Patient randomly assigned is to 1:1 manner to restrictive versus or liberal strategy. Randomized via central web-based system. Stratified trial site. Protocol amended in October 2019. Limited infusion to 1000 ml if vital signs stabilize and fell to the volume repleted. Free specified stopping boundaries for both futility or efficacy in either group at 1/3 or 2/3 of the recruitment. Study was stopped at the second interim analysis due to futility. There was no concern harm from the DSMB. Inform the consent required from patient or legal representative. Protocol advance monitoring for the first 300 patients in 10% random sample during the remainder of trial. Power of calculation: assuming the baseline mortality of 15%, absolute difference in 4.5 in restrictive group. 2,300 patients needed to have a 90% power at a significance level of 0.55. Setting for the trial: 60 US center, March 2018 to January 2022. This is a recently trial, guys. Population inclusion criteria: adult patient with suspected or confirmed infection, sepsis-induced hypotension, systolic BP less than 100 ml mercury or MAP less than 65, following more than 1000 ml IV fluid T1. Exclusion: more than 4 hours of since meeting inclusion criteria for sepsis-induced hypotension, more than 24 hours since the hospital presentation, and more than 3 liter IV fluid including the pre-hospital. Inability to obtain informed consent: pregnant patient, fluid overload, blood pressure is at a known or reported baseline. If any patient have baseline less than 100 systolic, then we cannot consider for the study. Hypotension suspected to from non-specific causes. Severe volume depletion from a non-specific cause. 12,876 meet the inclusion criteria, and thereafter 4,868 met the eligibility criteria. Then 1,563 randomized in restrictive group, 782, and liberal group 781 liberal patient. Comparing baseline characteristics: restrictive versus liberal group, generally well matched. Age, female, chronic heart failure, ESRF with hemodialysis, So first for 3.4 versus 3.5, systolic BP 93 versus 94, lactate 2.9 versus 2.9, median time from eligibility to randomization 61 versus 60 minutes, median volume of fluid administered before the randomization 2050 versus 2050. Intervention for restrictive group. If systolic BP less than 100 mmHg or MAP less than 65 after the recipient of 1 to 3 liter crystal oil, all bolus and maintenance fluid cease up to the 2 liter fluid bolus allowed, including the pre-randomization at the discretion of clinician. Following this is if MAP less than 60 or systolic BP less than 90, titration of non-epinephrine plus second vasopressor aiming the MAP more than 65. Once the MAP in target, then fluid limited to KVO, medication and nutrition. Then rescue fluid recommended for 500 ml bolus. Severe hypotension less than 70, MAP less than 50. Refractory hypotension less than 90, MAP less than 65, or non-epinephrine more than 20 microgram per minute or equivalent. Lactate more than 4 millimole more than or increasing after 2 hours of therapy. Sinus heart rate more than 130 for 15 minutes. Echocardiographic evidence of hemodynamic evidence or of extreme hypovolemia felt to be the best interest in treating them. Control for liberal group. Systolic BP less than 100, MAP less than 65 after the recipient of 1 to 3 liter crystal oil. Halt all maintenance. Prescribed 2 liter of randomization to be completed within 180 minutes. Second 2 liter can be held if volume restricted following clinical assessment following the first liter. If any following present, then further 500 ml bolus. MAP less than 60, systolic BP less than 90. You can give 500 bolus. Lactate more than 4 millimole per liter or increasing. Urine output less than 30 ml per hour. Heart rate more than 110. Requirement for vasopressor. Measure for clinical assessment. Rescue vasopressor allowed if severe hypotension. Defined as a restrictive group. Lactate more than 4 millimole per liter and increasing after 2 hours. More than 5 liter of total IV fluid given. Clinician manifestation of fluid overload of treating them felt as a best interest. Management common to both group. Assign protocol followed by 24 hours hourly assessment for early or any intervention. Protocol could be overridden at any time if felt in the best interest of patient. Vasopressor could be administered peripherally. 40% in restrictive group and 25% in liberal group had peripheral vasopressor infusion. Outcome from this study. Primary outcome is the death before discharge home by day 90 is a 40% in restrictive group versus liberal group 40.9. Estimated difference is 0.9. Efficacy and safety outcome. No significant difference in days free from the organ support therapy by 28. Day free from ventilator use 28. Day out of ICU from day 1 to 28. New intubation with mechanical ventilation by 28. ARDS onset between the day and day 7. Serious adverse events 3 versus 0 count of extravasation of vasopressor in restrictive group. All managed conservatively. This is a tabular form, the primary outcome and secondary outcome. Death before discharge by day 19, 14% versus 14.9. Strength for this trial. Randomized trial, multi-center trial with a broad inclusion criteria means result applicable to emergency requirement, early ICU practice, where the patient present in undifferentiated manner. The caveat to this that sepsis is a heterogeneous process and different causes of sepsis may respond differently fluid. Excellent design with a high internal validity with helps answer important and frequently occurring questions in prior limited evidence-based high level of adherence to protocol. 97% adherence or restrictive group, 96% liberal group with audited sample. This is impressive given time to constant in emergency department. Achieve separation of fluid administered in 24 hours. Almost identical amounts of fluid administered in both groups following the intervention of day 7. Excellent safety outcome reporting including on peripheral vasopressor administration. Weaknesses for this trial. Unblinded, single country may limit external validity, early cessation, large number of eligible but not enrolled. This may introduce the selection bias, includes the 900 as the study team unable to obtain informed consent. 887 patient not surrogate refuse the consent. 870 medical doctor or refusal, or 346 not excluded but not enrolled. Patient may not have been that unwell and baseline median systolic BP 90, low lactate level and ICU admission rate 63, and only 60 patients in restrictive group required vasopressor. Though dynamic method used to assess fluid responsiveness, fluid regimen do not account for the patient weight, size, liter in 50 kg patient, like to verify physiological response that in 120 kg patients. Significant amount of study were failed to individual clinician preference, introducing the bias. The trial compares the protocolized approach. Other approaches may have different outcome. ARISE trial fluid and andrometer shock to we will add more information. In further lectures or further video, I will explain the ARISE trial and andrometer shock trial. Author conclusion: the restrictive fluid strategy with earlier vasopressor use did not result in significantly lower mortality before discharge formed by day 90 and local fluid strategy. Bottom line for this study: the trial divided with the classic trial with respect to the time course of fluid restriction in critical ill patient. This paper will not change my current practice. It appears that both approaches are safe. Therefore, I will continue to use a multimodal approach to assess my patient and their requirement of fluid and make the decision to prescribe the further fluid or common vasopressor based on this assessment prior response to the fluid already administered. Thank you.